Hi guys, I'm Josh Schechter, and I'm going to talk to you a little bit about ocular ultrasound. I know this is a back to basics, and a lot of you are thinking, how is ultrasound, ocular ultrasound, back to basics? Many of you have probably never done an ocular ultrasound, but maybe by the end of this lecture you might think about it more and it might become one of your new basics. So, when we think about ocular ultrasound, or eye exam in general, we think about the fundoscopic exam, and we see these stuff, you know, we're all very good at recognizing it on tests. For many years we've looked at this, but how many of you have actually ever seen something that looked anything like what you see on screen in an actual patient? I think more likely, if you were lucky, you could see something that maybe looks like this, if you can get that much. And it's very difficult in our setting to get a good fundoscopic exam. The lighting's not good. If you maybe not even close to an ophthalmoscope. The patient might not be very cooperative. They might have findings that are difficult to do it. You might want to dilate and you just can't in that patient. Or sometimes you might have a patient that looks like this. I'm sure we've all had many patients that look like this. Try to do a fundoscopic exam on this eye. It'll be very challenging. So I think when we use the ultrasound, it can be very difficult in getting your the fundoscopic exam, but the ultrasound might be much more helpful. So how do you do the ultrasound? Well, you need a few things. First, you need the eye. Obviously, your patient's eye would be best. You need a tegaderm, some ultrasound gel, the ultrasound machine, and you need a probe. So what probe are you going to choose? You're going to choose the high-frequency probe. Most of the probes that we have that are high-frequency, it's going to look like this. It's your linear probe. It's the same you do all your procedures with or all your small parts probe. So how are we going to do it? Well, first, you're going to apply the tegaderm to the closed eye very nicely. This is to protect the eye from all the gel, all right? And then you're going to apply a very generous amount of gel, lots of gel. And the point of the lots of gel is so you don't have to push too hard, okay? And then you're going to scan the eye like you do everything else in two planes. And you're just going to go through it, and then the other plane. And it's very simple. That's it. Lots of gel. So what are we going to see? So here's your eye, right? And I'm not going to go through the exact details of all the anatomy, just some of the basic stuff. And here you have your anterior chamber. You have your lens. And then you have your posterior chamber. And you got the retina lining the back of the posterior chamber. And then you have your optic nerve sitting in the optic nerve sheath back here. All right? And when you do the ultrasounds, you're going to see all these structures pretty clearly. It's not the most difficult exam. And here you see. Here's your anterior chamber, your lens, your posterior chamber. You get the retina. You're not going to be able to see. It's just lining the back of the posterior chamber. And then you have your optic nerve sitting in the optic nerve sheath back here. So that's pretty clear. So just before we go on to how you're going to use this in the clinical setting, just some quick pointers. Lots of gel. I can't say this more clearly. You're going to use that gel so you don't have to push on the eye. You know, you don't want to sit there pushing on somebody's eye. First of all, in the setting of trauma, you definitely don't want to be pushing on the eye. It's also uncomfortable. Try sitting there pushing on your eye for a few minutes. Some of you might complain to me later you have a big headache. And so you can use that gel so you don't have to push too hard on the eye. And globe rupture is kind of a relative contraindication. Obviously, if there's an obvious globe rupture, there's vitreous coming out, don't think that would make good ultrasound gel. It doesn't, all right? You shouldn't do the ultrasound if there's obvious vitreous. And if you're thinking about globe rupture, tread very carefully because you can actually make it worse when you do the ultrasound. And the thing to remember, the most important question is there anything in the posterior chamber? Is there any echogenic structures in the posterior chamber? And the answer should be known. It should be a nice black circle. And so let's get how we're going to use this clinically. So, this first patient, he came in saying, you know, he's got some vision changes for a few days, some spots, some floaters, and then over the course of a day, his vision just kind of went away in that eye. He doesn't have any pain, and so you try to do your fundoscopic exam, and it's very limited. He's got decreased visual acuity, no other outward signs of trauma, and you throw the ultrasound probe on, and you can see here, we can't really see the anterior chamber or the lens, but you see this posterior chamber. And remember how I said there shouldn't be anything there, but it's not a perfect black circle. You see this line here, and it looks kind of like a retinal detachment because that's exactly what it is. All right? Here's a much more dramatic example where you can see the retina just sitting there, floating in the middle of the posterior chamber. And here's a video of this patient. So watch as the eye moves, how the retinal detachment will actually kind of float along with it. And you see how the retina just kind of floats along as it what happened? Here we go. And then you see how the retina kind of floats along. And just remember that for when we look at some of the other pathologies. So let's move on to our next patient. That's retinal detachment, and it's pretty obvious. So the next patient came to me. Okay. He was in a minor MVC earlier in the day. The airbag went off, but he felt fine. He went home. He didn't go to the hospital. But as the day progressed, he had worsening vision in his eye. So you look at the eye, there's no obvious signs of trauma. There's not a lot of swelling, but he does have some decreased visual acuity. So what you do is you do your fundoscopic exam, and it's very difficult. And you throw the ultrasound probe. And here you don't see that line like with the retinal attachment in our previous case, but you do see all this kind of stuff floating around. So there is echogenic material, which you don't expect to see. But you do see this stuff floating around. But notice how as the eye moves, it just kind of stays back there. It doesn't kind of move around like what the retina detachment did. And this is a vitreous hemorrhage. So it looks kind of like a vitreous hemorrhage if you think about it. And once again, you can kind of see that lens kind of pop in there, and here's your optic nerve kind of popping in and out. But here's your vitreous hemorrhage. So far we've had two pathologies that we've seen. It's pretty easily visible on the ultrasounds. So let's move on to the next patient. And he was working. Somebody was sawing next to him at work, and he felt something go into his eye, and he came in with some eye pain and a foreign body sensation. So, of course, you examine the eye. It's injected. There's no obvious signs of any foreign bodies that you could see. You're thinking maybe it's just a corneal abrasion, but, hey, I just heard this ultrasound lecture from Dr. Schechter, and it was awesome, so I'm going to try to put an ultrasound probe on it. So here we go. Here's the ultrasound on this guy, and you can see everything looks normal, but then all of a sudden this pops into view over here. And this is from last month. I had this patient, and this is not a retinal attachment. It doesn't look like that retina. It doesn't look like that vitreous hemorrhage, that stuff kind of floating around in there, but it looks like something's there, and there shouldn't be anything there. Okay? And you guys all see it, right? A little Yeti or something, right? Something that's abnormal. So we called ophthalmology. He got a CAT scan, of course. And you can see the CAT scan. He has this metallic foreign body sitting right in the middle of the globe. And he went to the OR later that day, and that metallic object was removed, and I think he did pretty well. All right. So that's some of the obvious uses that you can use ultrasound for. But what about maybe it's not just an actual eye pathology, but you want to do a fundoscopic exam, and it's difficult. But let's say this patient. So she came in. She's a young female, a little bit large. Comes in. She's had a headache for a few weeks, maybe some nausea, no real focal deficits, no fever. You're not really thinking meningitis, but you want to do a fundoscopic exam to look if there's any papilledema. So you try to do a fundoscopic exam, and I'm sure most of you have tried many a time and gotten to see something, maybe a little red line or something. But let's try with the ultrasound. So here's the ultrasound on this patient. And you can see all your posterior chamber. There's nothing echogenic in there. But if you look over here, here's your optic nerve, and then right above the optic nerve, where we would expect to see the disc, you do see that it looks a little bit abnormal. So you see that raised disc there, which is essentially just papilledema. And if we just compare that to a normal, so here's your papilledema, that's that patient, and then this is a normal eye, my eye. I know I have beautiful eyes. This is a normal. You see how it's kind of flat here, right above the optic nerve, and then over here you see the optic nerve sheath, and you see this just raised spot right over here, and that's papilledema. I think it's a lot easier to see this than on fundoscopic exam. I'm sure there's some people out there that disagree with me, and that's if you can do a good fundoscopic exam, good on you. But and it's one of the other uses of ultrasound, other than papilledema, you're thinking about elevated intracranial pressure. It takes time for papilledema to kind of come into view over time, right? So if you think about more acute setting of intracranial pressure. And that's where we talk about optic nerve sheath diameter. And I know as soon as you say the words ocular ultrasound, all of a sudden, everybody here probably thought optic nerve sheath diameter. So I have to talk about it because you got to talk about, if you're talking about ocular ultrasound, you're talking about optic nerve sheath diameter. So this is where you're concerned about elevated intracranial pressure, and it's a kind of a quick, non-invasive way to determine if there's elevated intracranial pressure. And the numbers to remember are 3 and 5. So what does that mean? So you have your ultrasound, and then you have your posterior chamber, but you see the optic nerve. And what you do is you measure 3 millimeters back into the optic nerve, and then you measure across. And that number in both eyes should be greater than 5 millimeters if you're thinking of elevated intracranial pressure. In a normal person, it should be less than 5 millimeters. So this is my eye again, and thankfully I don't have elevated intracranial pressure. So it is, you can see, less than 5 millimeters. Now, that being said, I'm going to be honest with you, I don't really use this in my clinical practice. There's a lot of talk, there's a lot of great articles on this, but I think in the setting that most of us are working with CAT scan and other modalities available to us in our clinical exam, you probably very rarely are you going to actually use optic nerve sheath diameter to make a real clinical decision to determine if this person has elevated intracranial pressure. Now, if you're working in austere settings, maybe somewhere internationally, where the only thing you have available to you is a drill and an ultrasound, and you're like, well, should I drill or should I not drill? Then maybe you can think about using the ultrasound. But to me personally, while this is really cool, I don't really use it so much clinically. And then I know some of you guys are thinking, you're like, all right, this is real cool for the sono nerds, but I'm just a basic emergency medicine resident or an emergency physician. I haven't done a billion ultrasounds. Can I really do this? And I think the answer to this is yes. So there's been a bunch of studies on this. So there's this study from 2002, and they did a whole bunch of ocular ultrasounds, from retinal detachment to vitreous hemorrhage to various other findings. And they found that emergency physicians with limited training are perfectly good at doing ocular ultrasound for these basic findings. And there are these two other studies that talk about just retinal detachment, but they basically found the same thing. Us as emergency physicians, this isn't a very difficult exam, and we can do it pretty successfully with pretty good sensitivity and specificity. So I think if you think about it, it might help you. Maybe it's 3 o'clock in the morning and you're like, should I call the ophthalmologist? Should I not call the ophthalmologist? You can throw the probe on. It's not going to hurt. All right? And then there are some other uses of ocular ultrasound that you might want to use. I didn't go over everything. There's lens displacement. You'll actually see the lens sitting somewhere where it's not supposed to be. There's retrobulbar pathologies, central retinal artery occlusion, globe rupture, but remember, tread very carefully in globe rupture. I mean, if you might see it on the ultrasound, but then kind of take the probe off and call your ophthalmologist. And then you can even just test extraocular movements. So like the image I showed you of the guy with a big swollen eye, it's really hard to kind of dig your way in there. You can just have them move their eye on the ultrasound. You'll be able to see it move up and down. And that's pretty much it. If anybody has any questions, you can keep them to yourself. So,